Good evening, dear students. I'm Dr. Halis, a board-certified hematopathologist and lecturer at Jian University. Our topic today is about blood transfusion reactions. First, we are going to define blood transfusion reactions, which is defined as any unfavorable event that occurred during or after a transfusion of blood and its component. We will classify transfusion reactions into acute and delayed forms. Acute reactions subdivided into immunological and non-immunological. The immunological reactions include hemolytic, febrile non-hemolytic, allergic, transfusion-related acute lung injury, anaphylactic or anaphylactoid reactions, while non-immunological include bacterial contamination and circulatory overload. We are going to give subdivisions of delayed transfusion reactions, which include immunological, such as hemolytic, transfusion-associated graft versus host disease, and post-transfusion purpura, while non-immunological form include transfusion-induced hemosiderosis and disease transmission. We are going to talk about each transfusion reaction briefly and give you important points about it. First, we have a febrile non-hemolytic transfusion reaction. What is this reaction? It's defined as 1 degree temperature rise associated with transfusion and no medical explanation other than blood transfusion. It means rising body temperature 1 degree above the pre-transfusion condition. And the causes include patient has immunological sensitization to donor's white BCs, platelets or plasma proteins, and common sources include prior transfusion, previous pregnancies, and previous transplantation. This reaction, the patient will present with fever, chills, and malaise. When we do investigations, the laboratory finding will be no red or pink colored plasma, direct Cummins test, and which is abbreviated as DOT, is negative, no increase of bilirubin, it means no jaundice, and no hemoglobin urea. We will how will we prevent this reaction? By transfusion of leukocyte, poor reduced red cell, and antibiotics are used to treat fever or are given as a preventive measure. These are the ways of prevention of this reaction. Other reaction is called allergic reaction. This is due to transfused allergens or soluble substances in donor plasma. The patient will have urticaria, or just called hive, in which the patient will present with itching. A reaction is not dangerous, but it causes discomfort and anxiety to the patients, commonly caused by transfusion of plasma containing blood components such as fresh frozen plasma, cryoprecipitate, and platelet concentrate. How we will treat this such reaction? First, we should interrupt the transfusion temporarily. It means not permanently. Keep IV line open with normal saline. We will give antihistamine because it's an allergic reaction. When urticaria disappears, we will resume the transfusion again. We will give oral or parenteral diphenylhydramine, it means alarmine. 550 milligram should be given 1 hour before and at the start of transfusion. If pre-medication fails, washed red cell should be used. We are going to talk about other reaction, which is called anaphylactic transfusion reaction. This anaphylactic is not like the allergic transfusion reaction. It is severe. It is life-threatening reaction, which occurs in rare patients who are IgA deficient and who developed anti-IgA antibodies. The patients who complain from this reaction will present with gastrointestinal upset, which means nausea or vomiting, flushing, urticaria, respiratory distress, it means dyspnea, and hypotension or shock. And from these signs and symptoms, it's obvious that this reaction is severe. How will we manage such a case? We should stop transfusion, keep IV line open with saline, give medications such as epinephrine, which is a vasoconstrictor and a bronchodilator. We might give corticosteroid also. Washed RBCs and blood components should be used in such reactions because they are severe and life-threatening. And transfusion of IgA deficient plasma should be transfused if available. Another reaction is called acute hemolytic transfusion reaction. It is the most common cause is ABO compatibility clerical error. As little as 10 to 15 ml can trigger a reaction and it occurs within 24 hours. So most common cause of acute hemolytic transfusion reaction is clerical error or ABO compatibility. As I said, can be caused by incompatible blood transfusion between donor and patient, usually anti-ABO compatibility, most commonly antibodies to anti-A, anti-B, or anti-AB. Red cell destruction due to complement activation by IgM antibodies in patient's plasma attached to antigens on donor red cell, causing RBC destruction intravascularly. This is the pathophysiology behind this kind of reaction. Patients complaining from this reaction usually presented with these signs and symptoms such as chills, fever, facial flushing, hypotension, renal failure, DIC and shock. DIC and shock are very dangerous presentation, or chest pain, dyspnea, generalized bleeding, hemoglobinuria, and hemoglobinuria. It means hemoglobin in blood and hemoglobin in urine, nausea, vomiting, gastric upset, back pain, and pain along the transfusion vein. Immediate action to be taken in the case of this transfusion reaction, we should stop the transfusion, keep IV line open with normal saline, check all blood components, label them, check the patient's ID for errors, usually due to clerical errors, for example, wrong patient or wrong blood component, etc. We we will notify the physician and notify blood bank and submit the specimen and submit the form. We will manage such cases by treating hypotension, renal failure, DIC, etc. Submit blood sample for blood banking or laboratory tests because, as I said, it's the most common cause of this reaction is ABO compatibility or clerical errors. Avoid, if possible, further transfusion till workup complete and or the patient recovered from reaction. To prevent renal failure, fluid, it means saline, are infused along with diuretic to increase the urine output. By these steps, you can manage such a reaction. During this reaction, these lab findings could be present pre-transfusion sample, reconfirm the ABO and RH and antibody screen tests, to avoid clerical errors and ABO incompatibility, while post-transfusion samples, we will do again the ABO, RH, and antibody screen. We will do DCT, it means direct test, urine for hemoglobinuria, take a sample of blood for serum bilirubin, check renal function test for blood urea and serum creatinine, and urine's output, so put Foley's catheter. Of course, we should do coagulation screen because of the presence of DIC. Okay, other investigation include transfusion-related acute lung injury or abbreviated astrally. This reaction, its symptoms occurs within 2 hours and may end in 2 to 4 days if treated, caused by donor leukoagglutination, which react with patient's leukocyte and produce aggregation. They are trapped in the pulmonary macrocirculation, causing endothelial damage by oxidative or physical damage. This was the pathophysiology of this reaction. The patients complaining of this reaction usually present with the following signs and symptoms: acute respiratory distress, fever, chills, X-ray showing pulmonary edema and hypotension. We will manage such a case and prevent it by giving steroid, methylprednisolone 30 mg per kg IV every 6 hours, divided by 4 for 2 days or 48 hours. Giving respiratory support, we should give oxygen because the patients have dyspnea and diuretic volume overload is present. We should prevent it by giving the patient washed red cell for future transfusion. Another reaction is called circulatory overload. Circulatory overload means excessive volume or high speed of transfusion of whole blood in severely anemic patients with compromised heart or lung function might precipitate congestive heart failure manifested by breathlessness, it means dyspnea, cough and distension of jugular veins. And elderly patients, infants, pregnant women are more prone to induce TACU. TACU, it means circulatory transfusion associated circulatory overload, can be abbreviated as TACU. How we are going to manage such a case? Of course, in severely anemic patients, it's advisable to give paclitaxel. Rate of transfusion should be slowed down. Diuretic should be given before transfusion. And in severe cases, of course, we should do exchange transfusion. Septicemia is considered another transfusion reaction which results from bacterial contamination of blood products, usually caused by the following microorganisms: Yersinia enterocolitica and Serratia, liquefacions. Symptoms appear rapidly, including fever, shock, renal dysfunction, nausea, and vomiting. We should stop immediately and treat with antibiotic because, as we said, it's caused by bacteria. Hypotension can be treated with vasopressors. Management and prevention of such a reaction. Give an appropriate antibiotic after culture of blood sample, of course. Care, phlebotomy during taking blood sample during phlebotomy process and blood component preparation, processing, thawing by sterile technique. All these measurements are taken to prevent septicemia reaction. This that I have previously mentioned, all of them were the acute or acute transfusion reactions. Now we have delayed hemolytic transfusion reactions. It's not they are called delayed. Why? Because they might not be recognized for weeks or months after transfusion. They are mediated by IgG antibody. Why IgG? Because one of property of IgG, they are not acute, they are delayed antibodies. Patients previously exposed to RBC antigen and has low antibody titer until exposed again in the future, so we will develop this type of reaction. Another reaction which is considered delayed reactions is called graft versus host disease, which is caused by donor lymphocyte engrafting in the recipient and reacting against host antigen. Patients at risk include immunocompromised patients, immunosuppression caused by anything, for example, congenital immunodeficiency or acquired one, such as patients receiving chemotherapy or radiotherapy, or newborn patients are at risk of developing this reaction, bone marrow transplantation, and also chemotherapy. Symptoms of the serious transfusion reaction: the onset begins 3 to 30 days after transfusion. The patient presents usually with fever, rash, diarrhea, liver dysfunction, and bone marrow suppression. We will prevent such a reaction by giving patients should receive leukocyte-free blood or irradiated blood component. If you remember in the lecture of blood components, to prevent this reaction, the irradiated blood components should be given. I mentioned it in that lecture again. And another reaction is called post-transfusion purpura. The patient usually presented with purpura and thrombocytopenia 1 to 2 weeks after transfusion. Thrombocytopenia, it means low platelet, so the platelet count will drop to less than 10,000 per microliter. And we will therapy and prevention include giving the patient corticosteroid, exchange transfusion, and plasmapheresis. Another complication or reaction of transfusion is called iron overload. Occurs in individuals who receive multiple transfusions. Excess iron accumulates in macrophage in various tissues such as liver, heart, and endocrine glands. It appears as dark brown granules in cells, may lead to organ failure, and treated by iron chelating agents. We could prevent it by transfusion with young red cells. The last transfusion reaction is called transfusion transmitted diseases, such as viral infection. Viruses that can be transmitted by blood include hepatitis virus, hepatitis B and C, retrovirus HIV, herpes virus, cytomegalovirus, and Epstein-Barr virus, parvovirus, human B19 parvovirus, prion, infectious particle of Creutzfeldt-Jakob disease. Bacterial infection could include gram-positive and gram-negative bacteria, sepsis, and Lyme disease. Parasitic infection, including malaria, Jake's disease, toxoplasmosis, and leishmaniasis. And by we are going and we reach to the end of our lecture. And thank you for your listening.